Bună ziua din nou! Mă bucur că am obținut conexiunea cu profesorul Aletaha. Daniel, you are online?
Hello?
Hello, Daniel. It's a pleasure to have you here. And for me, it's a great pleasure and privilege to introduce Professor Daniel Aletaha. Professor Aletaha is the chair of rheumatology at the University of Medicine in Vienna. And he is a wonderful expert in dealing with evaluation of rheumatoid arthritis because he has contributed to the major developments in this field in the last, I think, 20 years, Daniel? More or less. More or less. I'm afraid we or you or all of us are not so young as we pretend to be. Okay, Daniel, the floor is yours. It's a very big pleasure to have you here.
Thank you very much. It's always nice to see good old friends, as you say, and thank you again for inviting me. Unfortunately, only virtually this time, but the last couple of years I had the pleasure to be there at the meeting physically, and I hope that the times will change again and we will be able to see each other physically. Disease activity evaluation, I think, is a very broad topic. In rheumatoid arthritis alone, it's a very broad topic, and I have, I think, 40-45 minutes to speak, and it can be very dry. I hope it will be a little bit diverse. So I thought I might start with just laying out the concepts of disease activity measurement, and this is probably not only in RA. So one type of assessment is really measuring, quantifying disease activity. You can do that with single variables using the corsets here, or combine the single variables composite indices like SDI, CDI, DAS28. These scales provide a numerical scale that quantify, like a thermometer takes a temperature, they measure and quantify disease activity. Another type of assessment is assessing response, assessing the presence of a relevant change compared to some baseline. This is typically done in clinical trials when we want to know if patients have improved significantly. And we all know the ACR definition of response, which is the most prominent one. And there's the ACR 20, 50, and 70, as you know. And here's just the example of the 20. You can see the same elements go into the scales, into the measure, but in a different way. So it's not quantified, it's assessed by different rules. For 20% in this case improvement, and if you have to fulfill some of them, and if you have 5 of the 7, and etc., you get a responder status, which is yes or no. That's the second type. And the third type, of course, is now that treat to target is 10 years or older now, also treat to target is aging, Katalin. So it's the state definitions, and the state definitions typically we talk about remission as the most important one, are important targets for treatment. So they don't quantify disease activity necessarily, they don't tell us whether patients or how much patients have improved, but they tell us if patients are good. That's the point. Are patients in a good state? And remission low disease activity are typical ones, and the ACR-EULAR remission criteria mentioned here. You know, there's the Boolean and the index-based definitions, and we will come back to these. This is the general overview of the types of, disease activity assessments we can think of in RA generally, but probably also beyond RA. But one important question I think people often raise is the mixture of objective measures versus measures that come from the patient. And I think this has been a field of tension for many years. where we started with more or less objective measures, and then we claimed patient-reported measures should be part of a disease activity assessment. And now I think it's again people claiming that patient-reported outcomes could be a problem. So there's a permanent tension. And if you look at this slide that I just showed and look where you find patient-reported outcomes, you can see there is a few of them: Global Health Scale or Evaluator Global, Patient Global in here, and you can see in the ACR response definition you have several patient-reported measures. You have the Patient Global in the remission criteria as well as in the index-based. You have also a clear statement of treat to target already in the initial sort of addition, that decisions should be based on a shared decision. So shared decision obviously means that the patient should be considered with their opinions and attitudes as much as the physician. So you can see this is the overarching principle A in the treat to target recommendations, but you find it everywhere. You find it in the UPLA, in the EULA recommendations from 2016, also in the most recent update, must be based on a shared decision. In the ACR you find really a lot of wording that indicates the shared decision, and the UPLA recommendations you find the shared decision term as well. So shared decision is something important, and so people might well argue that when talking about disease activity assessment in rheumatoid arthritis, the patient and the physician should be, views should be combined, or at least both of them should be considered. Now there are, who is right? And that's a very important question, because we know that patients and physicians often or sometimes disagree. And here's some reason or some perspective of the different stakeholders. And of course, patients' main problem is pain, and so patients feel the pain. So pain is the most important problem for the patient, whereas for the physician it's not so much the pain. Of course, we want to treat patients' pain, but physicians care about different things, about disease activity, about the long-term consequences. Patients want to be better today, and the fear of today is often greater than the fear for tomorrow, where the rheumatologists have the perspective of the long-term damage and consequences of inflammation. It goes even to cardiovascular complications of or consequences of chronic inflammation, etc. So we have several reasons for this for disagreement, and there is a tension field between patients and rheumatologists that we need to consider thoroughly. A very simple example, I think, that many years ago I just did by simple correlation. I looked at the correlation of patient global and the evaluator global with tender joint counts. And you can see are correlated more or less to the same extent. And the difference is not significant between the two correlations with tender joints. Now, swollen joint counts, for example, if you take that, you can see that suddenly the patient global correlation with swollen joint counts drops, whereas the evaluator global stays stable or increases a little bit, with a clear difference in the correlations of the views of patients and physicians towards swollen joints. And we know that as physicians we care a lot about swollen joints. If a joint is not swollen, we tend to value it much less into the equation. And this just indicates that the perspectives are different, and that this may lead to a disconnect, which we can see in studies like here that have been published also 10 years ago, where we can see, depending on the or stratified for tertiles of swollen joints, so lowest swollen joint count group, middle joint count group, and high joint count group, how patients and physicians in their global assessment disconnect on the group level. And you can see that physicians clearly drop their assessment when there's a few joints. The more joints, the higher they get. They still don't reach the patient global on average, and we know that the mean difference that we see in table 1 of clinical trials, the mean difference between a patient global and a physician global is about 1 centimeter on the 10 centimeter scale. But this discrepancy or disconnect is higher if you have lower joint counts. As Paul Studenich has shown in a nice analysis, you can actually look at this disconnect between patient global and physician global. So if you take the difference, patient minus physician global, you get a scale that goes from 0 up towards patient global higher, or from 0 in the minus scale to the physician being higher, which is rare. But you can now do modeling, and what we did was we modeled this disconnect between patients and physicians using the variable pain. And pain clearly drives patient global more than the metrologist's global or the physician global. So you can see as soon as the pain level of a patient is higher than 10, 15, it starts to have a disconnect to the physician global. And this is modeled for everything else, for all the other variables in this large cohort being the same. So this is modeled for fixed values of other variables. So this is the sole effect of pain on the disconnect between patient's views and metrologist views. And now when we do the same thing for swollen joint counts, keep everything the same but just increase the number of swollen joints, you can see what is expected, that this curve shifts in the other direction. If you have really high joint counts, you can even get a situation where you have a higher physician global than patient global here. But you can see the lower, and this is consistent with the previous slide that I showed you, the lower the patient, the swollen joint count number, the more likely you are that the patient global exceeds the physician global, because the physician global will be very low, because we as physicians look at joint swelling as a clear hallmark of inflammatory disease activity. This is important to know. There is no clear solution to that, but it's important to know. Now, coming to leaving a little bit the patient-physician field and coming to the, what I mentioned in the beginning is now the most important thing in rheumatoid arthritis and many other diseases, is the definition of the treatment target. And the focus, of course, is remission, where we many years used this term remission without clearly giving an exact meaning to the term. We just meant that remission is something where you simply take the disease process, the inflammatory disease process, and you eliminate it. And the idea is really, if you eliminate it, you don't have the chronic damage coming from chronic inflammation, but you also have no direct effect on function from disease activity, from the pain, from the stiffness, from the swelling, and also no consequence from the chronic damage on function. So ultimately, if you try to treat patients very early and very consequently to remission, you have patients that are on treatment, but will ultimately have no stigmata of disease. They will not only not sit in a wheelchair, they will also not have deformed joints. They will also not be recognizable as patients with a rheumatic condition. And that's the ultimate goal and the reason why we are talking a lot about early treatment, early diagnosis, and consequent treat to target towards remission. So the focus is remission, and these are the 2010 remission or 2011 remission criteria. There is this index, the main edition is for clinical trials, And there is a separate edition that was published in the same document for clinical practice, with the only difference that there is no acute phase reactants included here. So here you have two options for defining remission. One is a Boolean based, which is requiring an intersection or multiple conditions to be fulfilled, and you are well aware this is swollen joints and tender joints, patient global and CRP, all need to be one or less, and then if you have fulfilled these 4 criteria, you're in remission. The index space is not much different by content, as you can see. You have the swollen, the tender joint, you have the patient global and the CRP, you have also the evaluator global as an addition. The difference here is that you have the sum of them required to be below a certain cut point. So this is in some way different, and we will look at the comparison in a moment, but this is to some extent different because the sum allows one of them, in theory, being higher than 1, as opposed to here, while if the others are all normal, you will still be in remission. Here, as soon as one of the variables is higher than 1, you lose remission. And you can see the clinical practice edition is without the CRP here, and the S-dye without CRP here, and that's the C-dye, as you know. So some of you may ask, what happened to the DAS? What happened to the DAS28? And this is a scale that we use to, that we are all familiar with, and has been introduced in the 1990s and has been around for a long time. Now, the DAS28 has a problem in remission, and we've discussed it often enough. It has a complex formula with weighting and transformations, and it works well in moderately active patients. But in remission, you have the following problem. If you look at patients in DAS28 remission who qualify as remitters, you can see that only 70% have really 0 swollen joints. And the remaining 30% of patients have up to 16 joints in theory. And also in practice, you can find these patients. This is based on evaluation of a real-life cohort. And you find a few patients with very high, not many of course, but you can see there is 30% of patients that do have 1, 2, 3, 4, 5, and even more than 5 joints. And Desiree van der Heijden has shown the same thing for the DAS28 remission, that you have this 70% with no swollen joint, and then you have 1, 2, 3. The remaining 30% have active joints. Now, if you ask rheumatologists how many joints are acceptable to claim remission in a patient with rheumatoid arthritis, and you do a survey, and we did that, then the median the median response is 1. So 1 seems to be tolerable, and although this survey was 15 years ago, and I think it would have changed. We haven't redone the survey though. The problem is really the weighting, as I mentioned. You know the formula of the DAS28, and this is really giving you the lines for contribution of the individual variables to the DAS score. How much does it add to the DAS? You can see that 28 swollen joints contribute to the DAS score with 1.5 on the scale. You can also see that the same 1.5 can be achieved with 7 tender joints. So 7 tender joints and 28 swollen joints are equivalent by contribution to the DAS scale, which is, of course, partly related to the different weighting, as you can see, in conjunction with the square root transformation. But also for the acute phase response, you can see that even normal acute phase response, like an ESR 15 here, contributes about 2 to the DAS scale. And if you have a patient, just within the range of normal, moving from 15 to 5, for example, you can see that this improves the patient's DAS score by a whole point. So this is a little bit the issue, the high weight for the swollen joints as opposed to tenderness, This creates the problem in remission. And the strong weight of the acute phase creates another problem. And people have recognized it, and they've said, well, we need to change the cut point of remission for the DAS28. So what you can see here is proposed cut points for the DAS28 CRP cut point that would correspond to a CDI remission would be 1.9. For the ESR, it would be 2.2, clearly lower than the traditional cut points of the DAS28. But if you do that, and you can see that for the red line and the green line, this is the modified cut points of the DAS28 ESR and CRP, and again, you can what's shown here is the joints active despite being in remission. And you can see it's here, again, 70% of patients in DAS CRP remission with a cut point that's much lower have zero swollen joints, and the remainder has, you can see it's not many patients here, but there's patients, quite numerous patients that are active despite being in remission. Whereas the CDI, you can see, doesn't allow more than 2 in any patient, more than 2 swollen joints. Now, the changing of the cut point is not the solution to something that's a problem because of a complex formula. Changing the cut point doesn't improve that problem. I think that's the point that we learned from this exercise here about changing cut points. But there is another point, and then I'm finished with this topic. It's the strong effect of on the acute the strong weighting of the acute phase is a problem if you have therapies that primarily or predominantly affect the acute phase in addition to the clinical efficacy. Now, if you take non-cytokine targeted biologics like rituximab or abatacept, you can make a comparison between DAS remitters in blue and ACR 50 and 70 responders, 50 in green and 70 in red. You can see about, for both, the rate of remitters is about the same as the rate for ACR 70 responders, which is acceptable from a clinical perspective, probably. 70% improvement corresponding to something close to remission at least, that would be reasonable. Although you would maybe think about 90% or more to be in remission. But the point is a different one. If you use cytokine-based therapies, particularly IL-6 targeted therapies, where there is a strong effect on the acute phase component, on the disease activity acute phase component, then you suddenly note that the ACR response rates and remission rates take a disconnect of the you can see that the DAS remitters here are increasing, and you can see for the this is option and this is radiate. In radiate, you can see that DAS remitter rates are even higher than 50% by the ACR, because the weight of the acute phase in the DAS is so strong, or much stronger than in the ACR response, where there is also acute phase, of course, so that it creates an overly positive impression on of course, the remission rates. It works clinically, but in comparison to other scales, the result of the DAS scale depends on the type of therapy. And a good disease activity tool should, give oral therapies more or less the same chance, and not, give different results based on different types of therapies and not on their efficacy. And you can even see that for TNF-targeted therapies, where also clearly the DAS remission rates in the COMET trial, for example, were much higher than the ACR 70 rates, and almost or little lower only than the ACR 50. So this is for the explanation where the DAS and DAS28 really is in the remission definition and why it is not there. It's the swollen joint problem, so the weighting, and it's also the strong weight of the acute phase. But I don't know how much time I have left, but another question, of course, is this is not a uniform definition either. So we have Boolean and we have S-die and C-die. And if you let us compare these three and say, are these really equivalent? Are these the same? And we did this exercise a couple of years ago and published it in 2017. What we really did, we took three trials, Aspire, Attract, Go Forward, so golimumab and infliximab trials. And we said, okay, what if you have the criteria for the Boolean? What would you need for corresponding cut points for S-die and C-die? We know that the current cut points are these ones, and the same thing the other way around. Well, let me start with showing you this. If we take the S-die remitters, you can see that you would, in order to achieve the same percentage of responders as in the S-die remission, you would need to change the C-die cut point to 2.7, 2.8, 2.5. The real one is 2.8, so they're very consistent. And vice versa, if you take the C-die remitters with these rates and you try to match the S-die cut point so it gets the same number of remitters, you can see you're more or less with 3.3, which is the cut point. If you do the same thing with the Boolean, which are a little bit more stringent because they require each of them to be less than 1, you can see that the S-die and C-die cut points would need to be reduced, at least to some extent, because they're a little more stringent. And in order to match them, we would need to have lower cut points to really have the same numbers. And if you do the other thing, you take S-die and C-die remitters and try to change the cut point of the Boolean criteria from 1, you see you need to increase them so you have the same level, so the same number. So they are not identical, but they are, S-die and C-die are very close, more or less identical. But with the Boolean, they are slightly more stringent. And you can now say, well, this is minor differences compared to the DAS, but why is the reality still that the ACR-EULAR criteria are not used as primary endpoints in clinical trials of rheumatoid arthritis? And this is just to show you why. Because if you look at how much power you would get from using the Boolean, the S-die, the C-die, or the DAS28 criteria, if you have a placebo-controlled trial with 100 patients in each group, you can see your power for the Boolean is 56%, and your power in the same cohort of patients would be 97%. And the same if you take another trial data as a basis, it's 77 and 98% power. So you could ask the question, how much patients would I need to enroll in a clinical trial if I use one of these outcome measures and want to have 80% power? You can see you need 173 patients in each group if you take the Boolean criteria as the endpoint, and you only need 52 patients if you take DAS28 CRP. And the same down here. So this is the reason why lots of studies are still showing you DAS remission rates, knowing exactly that this is not remission, knowing exactly that patients with DAS28 remission have swollen joints, knowing exactly that there is other tools that are more stringent and more consistent with physicians' views on remission, like the Boolean or S-die, but the practical reality is the DAS is often chosen because it's called remission and it requires a third or a quarter of the patients to be enrolled in clinical trials. So this is convenient, but it's not completely honest, I could say. And maybe the DAS28 remission should be called low disease activity or something else, but it's convenient because it's still a remission and can be make studies much more feasible than they otherwise would be. So brings me to the question, is remission necessary at all, or is low disease activity acceptable? You can look at health assessment questionnaire or SF36, so physical function and quality of life or activities, performance of daily living. You can see that remitters have a better HAQ score than low disease activity patients if you look at all the different domains. And for the SF36, you can see the same. It's the scale is inverse. That's why there's the remitters have a wider area, and the low disease activity are more narrow. I'll go over that more quickly, but my point here is that remission really improves also cardiovascular risk factors, like shown here for CDI remission on much lower CRP, much significantly lower systolic blood pressure, and in fact also significantly lower composite risk scores for cardiovascular disease, like the SCORE. Comorbidities are lower if you have remission, and you can see that, for example, coronary heart disease in SDI remission and remitters is lower significantly, almost significantly, and osteoporosis is also significantly lower than those who don't have it. Now, also the treat to target recommendations say, well, the primary target is remission, but if you read on, it says, well, that it might be in long-standing established RA, it might be an alternative. And the reason, one reason where you could use low disease activity as an alternative target, meaning you don't need to change therapy because your patient is still in low disease activity and not in remission, is when you are treating your patient with a TNF inhibitor, for example. If you look at that, you can see that for methotrexate only patients, the progression of structure is clearly almost linearly associated with the presence of these 4 disease activity states. So the higher the state, the more progression. You can see more or less the same thing for TNF inhibitor treated patients, with the difference that in low disease activity there is still 0 progression on the group level. And in individuals you will only have a few with progression. So this is an argument, if the patient is fine and on a TNF inhibitor, you might not need to change treatment, even if you're in low disease activity and not in remission. Whereas with methotrexate treated patients, you may think about it, because if you're only in low disease activity, you may lose something, and in individual patients, it might be even more. Now, this dissociation of inflammation and damage has been shown also for etanercept and not infliximab only, as in the previous slide, but we've also shown it for tocilizumab and rituximab, that there is such a disconnect that allows us to claim that patients on these compounds who get close to remission but do not reach it are of very little risk of structural progression, and therefore may have low disease activity as the ultimate target. And the other reason is, of course, a measurement problem and the patient-reported outcome issue that I discussed in the beginning. When you look at patients who, for example, for the Boolean criteria, fulfill 3 of the 4, but not 4, you can see that among this group that reaches 3 but not 4 of the Boolean criteria, 60% miss the patient global criteria, meaning everything else is less than 1, but the patient global is the one failing, and therefore there is no remission. And if you can look at this, you can predict this and associate this with pain scores again, and it says the probability of missing remission, Boolean remission, because of the patient global, with everything else being in remission, is clearly increasing with pain. And if you have a pain score of 20 or 25, your probability of just not reaching remission because your patient global is too high is already 80%. No swollen joints, no tender joints, no CRP. So people have said this is may not be a relevant problem, but if you look at comorbidities, the most common comorbidities, you go based on the Comoro study, depression is one of the most prominent comorbidities in RA, and depression is linked to less pain tolerance, higher pain levels. So the patient global is an issue in achieving an issue in achieving disease activity remission by the Boolean criteria, and we have proposed and analyzed that you can change the Boolean criteria by changing the patient global cut point from 1 to 1.5 or 2.0, 2.5 and 3.0, and that you really can increase the 6 months and 12 months remission early and established RA, while leaving the cut point for the others, other variables in the Boolean at 1. So currently there is work in progress that may suggest to change the Boolean cut point to 2 in the remission criteria in order to achieve a better also consistency with the other scores like the SDI. And you can see if you increase it, the concordance with the kappa, the agreement with SDI increases. So let me move on to the final question: is clinical remission enough? And this is the opposite to the question I just asked. And I don't know how much time do I have. I think can I have a few more minutes? It's my final set of slides, because I just...
Daniel, absolutely no problem. Take your time.
Okay, thank you. So I just asked the question whether remission is always necessary. That was the previous chapter. Now we agreed that I'm not sure if we agreed, but we said that possibly remission is not always necessary if you have biologic on board and do not progress, if you have isolated pain and that increases your patient global, it might not be necessary to change DMARDs. But other people now say, well, clinical remission is not enough, so we need even more than clinical remission. And that's also a fair statement. And if you look at the T2 target research agenda in 2014, it said, well, we don't know whether targeting really an imaging marker in ultrasound or MRI really improves outcomes as opposed to targeting only a clinical disease activity like swollen joints. Now, the study that you would need to understand whether imaging in treat to target has an added value is to randomize patients into a treat to target arm 1, where you have the clinical target only, and then an arm 2, where you have the clinical target plus an imaging target. Now, these two groups have the same escalation of drugs and the same sequence, but they have different, these here will be changed much more frequently, because they will also be changed if clinical targets, clinical measures are on target, but there is science on imaging, and these will not be changed with the imaging. Now then you measure at the end and you see if there's any relevance in clinical difference in the outcomes. Now these studies have been performed, and there's an Arctic trial, this is a study, a large study that did exactly the same thing, clinical target versus clinical plus imaging target with a composite endpoint of at 16 and 24 months for clinical and structural outcomes, but the difference was non-significant. It was p-value of 0.5 with 20% versus 19% achieving the target. A little more on the imaging, but really not significantly different. And if you look at the disease control in both arms over the 2 years, they are very similar. Now you could say this is only one trial, but there was another one which more or less had a very comparable design. which I won't go into detail with, but it also showed that, adding an imaging target to a treat-to-target approach does not improve clinical outcomes significantly. There were no differences in the TASER trial in DAS, HAC, or SCR corset variables at any point in time. And this is, when you talk about early RA, I go over this a little bit because it's time-consuming now. But if you look if you look at MRI, you find the same thing. And there was another study for MRI, same concept with clinical target here and clinical plus imaging target, meaning bone marrow edema, absence of bone marrow edema, and here you can see the endpoints. Essentially, the primary outcome was failed. This is, of course, not feasible anyway to do multiple MRIs as a follow-up in disease activity, but the concept was important to show, and it showed that it's not significantly different, but it showed that in some of the secondary outcomes, there might be a benefit of changing therapy in clinical remission when there is still subclinical activity. But these were only the secondary outcomes. Now, doing repetitive MRIs is not something we can do in clinical practice to increase sensitivity of our assessments. But maybe there is some really easier way to do that. And I was really wondering, always thinking about imaging and biomarkers to increase our sensitivity. But when you look at how we assess joints clinically, physically, without any imaging tools or lab tests, the degree of joint swelling is a continuum, and we make our decisions somewhere here and here, as clearly not swollen and clearly swollen. But of course, this is a continuum, as we know, and the question is what happens with the middle zone? Why are we as rheumatologists so much disagreeing when we do joint counts? And this has nicely been shown by joint category, how much, where the kappa is. And a kappa of somewhere here would be good, and this is moderate, and this is really poor agreement between physicians. And it depends, of course, on which joint you assess, but it's poor agreement. It is probably because of this middle zone, this gray zone, or yellow zone in my case. The question is, what are we doing clinically with this doubtful middle group? And when you go back to the EULA Handbook of Joint Assessment, it says, when in doubt, a joint should be considered as non-swollen. So what are we doing actually traditionally, if we do it properly? We are laying out our clinical assessment for specificity. If we're in doubt, we say it's not swollen, instead of potentially claiming swelling in a non-swollen joint. Now, this is clearly reducing sensitivity. And the question is whether this doubtful clinical situation also represents an intermediary inflammatory situation. And you can do this with ultrasound. You can have physicians rate the joint for non-swollen, doubtful, or clearly swollen. So two clear categories, and let them allow them to rate something as doubtful. And then you take two physicians and you take a score from 0, 1, and 2. This is clearly not swollen, clearly swollen, and doubtful. And you have two physicians, that's why you have intermediary categories. And then you do the ultrasound. You can see the grayscale increases. You can see the power Doppler increases in the middle groups as well. So if both are in doubt, it's in the middle. If both are clearly saying swollen, it's the highest. If both say it's not swollen, it's the lowest. And if they disagree to some extent, and some of the means come by disagreement, it's somewhere in the middle as well. If you look for osteophytes as a negative control, you can see there's no association with this rating. So my argument now, and this is my final slide, and I'm sorry for running a little bit over, is maybe change the type of approach and philosophy we use when we assess joints, and say when in doubt, consider a joint in an RA patient as swollen. And you know the ACR 2010 classification criteria say, as long as you have one swollen joint that's clearly swollen, consider everything else that's tender as an active joint. Now, this would be a way to improve and clearly increase sensitivity of disease activity assessment without any additional tool. But it means also that we need to change our thinking. So assessment can be done by different, to summarize, by quantification, by using response measures, or by using state measures. PROs are mentioned. Patient-reported outcomes are important parts of composite measures, and they may be in disconnect with the physicians and the objective measures, and we need to consider that. The ACR Euler Boolean criteria are somewhat more stringent than the SDI and CDI, mainly because of the patient global, and we talked about maybe changing the patient global threshold. All of these together are much more stringent than the DAS28, which is still used a lot because it's convenient in clinical trials because of sample size and power. Sustained clinical remission is the ultimate goal. These were a few slides I went over very quickly. But not every patient needs to reach remission. We made examples for that, including patients on a biologic or patients who are, have a lot of pain or depression, fibromyalgia, and therefore fail to reach objective markers of remission and PROs. Imaging remission can be a target in clinical practice, and ultrasound may be used for that purpose. There was a little benefit in these trials, but not the significant one. It doesn't mean that we should not use it, but it means that we should not claim that this is state-of-the-art for treat-to-target in rheumatoid arthritis. And maybe we can increase the sensitivity of clinical exam by simply considering doubtful joints as active joints, and therefore save a lot of time and money for imaging and potentially biomarkers. So with this, I'm at the end of my presentation. Thank you very much for your attention.
Thank you very much, Daniel. And we have a minute or two for any question from the audience. Actually, may I ask you a question? In your daily practice, would you be glad just not to use DAS28 and move to SDI or CDI? And regarding the final endpoint, would you like to go just to reach the ACR Euler definition of remission?
Well, I think in clinical practice, it's we use the CDI because it's convenient for the acute phase. We can use it in any patient regardless of the availability of the CRP, and that's how we use it. We say we go for low disease activity or remission. When we reach low disease activity, we look at the components as well before we potentially overtreat patients. And there are these patients that also in the CDI have high patient globals that are in disconnect, and there's other reasons for this than inflammatory disease. So we use the CDI and we go for remission, but with low disease activity we consider the components.
Okay, and the second one, how often are you using ultrasound just as an add-on to your clinical evaluation in daily practice?
Quite frequently, but more in a situation where the consideration is treatment reduction, where patients are doing fine for a while clinically. I feel like I do not want to miss subclinical activity if I remove or reduce treatment. So here the ultrasound to me is a good tool to support this decision.
Okay, and just regarding your answer, if a patient is in remission and or if it have a disease which is well controlled with the treatment he's taking, how often are you proposing tapering, regardless the type of treatment, biologic or not biologic, how often are you proposing tapering?
Well, I think that the patients are coming with their proposal often first. I usually, I'm not in a rush, I'm not in a hurry. I think we still have not enough patients in remission, so we should not risk those who are in remission to flare. I like to have my patients in remission for a year, and then we usually start the discussion. And I think it's still a case-by-case decision. Also, the type of treatment that you reduce is a basis for discussion, because we usually patients usually want to reduce the methotrexate, and we sometimes start with the biologic.
Okay, thank you very much. It was a pleasure as always, and hope to meet you soon again. We'll meet you in fact on October 10th at the online conference of rheumatology, which will be organized instead of the real congress, but hope to meet you in person soon again. Thank you very much. A big applause.
Thank you. Thank you.
Have a nice day.